The topic is challenging ILM peeling by novices.
So coming to a case, first case was for 52-year-old female, who is operated for. This is a 52-year-old female case, which is operated for a full thickness macular hole. So after conventional core vitrectomy, post-thyroid got stained with a triamcinolone acetate. You can see here the surgeon is missing view constantly, poor focusing and overstrain of the vitreous. The surgeon landed up in a big retinal tear. So after the PVD was induced carefully and the vitrectomy was completed. After completing the full vitrectomy, the endolaser was given around the break and you can see the fovea was just paired. After the ILM was stained and very carefully the ILM peeling was completed and starting away from the retinal tear. And finally the case was closed with the gas tamponade and post-op-positive was showing the closed macular hole and vision improved to 6/9. Coming to a second case, which is same operated for the full thickness macular hole. In this case, the surgeon started ILM peeling close to the fovea and landed up in a retinal tear. So after peeling was completed and we have given an endolaser to the break.
This is an initial case scenario. So learning thing is the PVD induction should never be done towards the macula. In a macular hole case, it should be always done away from macula, maybe nasally, superiorly, or wherever you are comfortable. And if you have a break, you should stop immediately. And ILM peeling should be done away from the fovea. It should not be started very close to the fovea, so that even if you make a break, fovea hole or fovea edges should not get damaged. So this is learning, and you should not stain very thickly with a triamcinolone acetonide so that you can see the edge of vitreous at the edge of the disc margin, so that PVD induction can be done carefully. The next slide.
Coming to the third case, which is also operated for a full thickness macular hole. After completing the macular rexis, the surgeon tried to enlarge the ILM peel area and instead of getting edge of the ILM, accidentally injured the artery. It started oozing continuously, measures like increasing IOP also failed. Usually such a bleeding stops at automatically increasing the IOP, but which was not stopping. So finally, the endolaser was given to stop the bleeding.
So in this case, take-home message was then the mentor came on and control the bleeding. Measures to control the bleeding is, first of all, eyelid peeling should be tried. Eyelid should be pinched away from the vessel. Should not be pinched over the vessel. Vessel should be used as a guideline to focus, not to start the eyelid peeling. And other measures to control bleeding is increasing IOP, giving laser to the leak, can try at 40 if it is a small weak leak, or you can use high viscoelastic also over the break, which can stop the bleeding, and then you can proceed with the eyelid peeling. Should be started away from the peel area, and you should not continuously try to drain the blood immediately, because that will remove the clot and continuously cause reoozing. So you should wait for the complete clot formation and then remove the blood which is clot came over the macula for some time. This blood can also act as a template for hole closure also. So should not be in a hurry to remove that oozed out blood. Should wait for them.
Coming to a last case, which is this is a case of 73-year-old male, one-eyed patient, case of total RRD without visible retinal break, who was undergone for penetrating keratoplasty and trabeculectomy with iris clot. Case started with a careful vitrectomy. During vitrectomy, the macular hole discovered as a retinal detachment. The ILM was stained with a brilliant blue and peeling started very carefully. And the ILM peeling was done in the detached retina, taking care the ILM should not detach from the macular hole margins. And this is the floating ILM was plugged in the macular hole in detached retina, and the retinal tear, the retinal defect closed with the ILM plugged in it. After that, the fluid air exchange was done. 360-degree laser was given, and the case closed with the SF6 20%. Poster posterior showing the attached macula with plugged ILM hyperreflectivity with vision improved to 660. Thank you.
In this case, this is a special case in which it was a one-eyed case which has undergone trap, post-PK and iris claw IOL institute. So in such cases, usually as a standard case, if you don't find any break, you prefer to have encephalic bend. In this case, because of trap, we didn't plant encephalic bend. Oil implantation was hesitant because of migration of oil into the AC because of iris claw IOL. So we was hesitating to put oil, silicone oil. And since there was a hole formed on the posterior pole, a lot of doc surgeons prefer PFCL, but I avoided putting PFCL. And we succeeded in attaching the retina without using PFCL, silicone oil complication, without belt buckle, and succeeded the case with normal, good vision improvement, normal IOP, and patient is happy, one-eyed patient. So you should, this case shows the importance of ILM as a autologous tamponade, which can be used in a lot of multiple macular scenarios, which can act as a savior for VR surgeries. Thank you.
I thank Dr. Priyanka and Dr. Anabosa for this presentation. Over to you, panel discussion points.
I'm sure you were expecting all these troubles, so it really can't be a super snag. If you're already with her, you know that it's a learning curve. So it's basically a learning curve problem for her in most of the what she showed. I mean, nothing.
Yeah, ma'am, but then this break near the phobia, it should.
I agree with it, but what I'm trying to say is there's no super save here because you're expecting it. You're expecting such a thing, your mentee is just learning. So these are surgical mishaps which happen in everything, and you are ready to take over.
Yeah.
And just saying.
No, my super save in this is if you find a break near the fovea and if you give laser, that atrophy will hamper close macular closure. In this super save was we luckily got good macular closure in all these cases with the nice post-op results. That was a super save, and laser has to be done minimal.
Well done, that I don't deny.
You are the super saver. There is no super save here. So, first of all, let me congratulate you. Good 4 cases.
Thank you.
Surgical retina. Number 1, PVD. Very important learning lesson. It's like you are maneuvering around the disc and removing the hyaloid right from the disc.
Yes.
Not near the macula.
Yes.
And even if, like, another problem is that, the triamcinolone was so much more when we were trying to induce the PVD that you lost track of what was happening in the retina.
Yes.
That is why the tear came.
Yes.
So when we are inducing the PVD, probably the initial bit of triamcinolone, if you remove quickly, then there will be a thin translucent layer through which you can see the retina. And if there is some traction there, we can immediately stop that. So from the macula also, sometimes you may require to remove the hyaloid, maybe with the forceps or with the suction, but you have to be very clear about what your macula is getting traction or not.
Yes.
Number 2, very good learning point, because you are starting to peel the ILM very, very close to the macula hole. Mistake. You have to first of all do an OCT, find out where the ILM is thickest, and either superior or nasally you can hold the ILM and start. And very close to the fovea is not a very good thing.
Yes.
But it was a very, very small, tiny hole that you made.
Yes.
And you lasered it heavily. I think that was not
could have been avoided. It's true, sir.
Because now the large macular hole we are not lasering.
Yes.
And we are removing the ILM on top of the small hole.
Yes.
So it need not have a laser around.
That is
maybe a
extra.
row if maximum.
Yeah.
Number 3, bleed from the ILM. Yeah, just like in the previous case, pressure rise, probably a tamponade, etc. RD with macular hole, you are doing an ILM peeling. There are 2 techniques. One is about using a PFCL and ILM staying under the PFCL to remove it and hold it. The way you use, you should always peel the ILM from the disc towards the, so in some cases it was the other way around, etc.
Actually, it started with from the disc, but then to get clear around it, I have to peel so that I should not detach it from the whole margin.
Yeah, so maybe you can just put it on from one side, you can put a fold into the, you need not peel all around. See, basically you're putting an ILM flap, so you can do that. Another thing is that, if you do an air fluid exchange or something like that before the ILM peeling is attempted, then you will get a more flatter retina to start. Thank you.
But then in this case, if we flat the retina, we cannot plug. I am hesitant to plug the ILM inside because if we touch the RP, it can lead them to scar formation or pigmentation. So in such cases,
in a retinal detachment case, when there is still fluid, if you put in brilliant blue green, it will go subretinally also.
yes, but then usually what happens, if you make a retinotomy close, in this case, light came out from the retinotomy completely, and we.
Good. But the last mistake that you did was you overshot time by 30 seconds.
Sorry, sir.
That cannot be managed.
Sorry, very sorry, sir.
Up here.
Now that we are coming to the end of the session, the moderators and the judges also will receive a memento.